So we'll begin with the case. It's a 23-year-old female with a chief complaint of seizure at triage. The story is the triage nurse witnessed a tonic-clonic seizure for 1 minute. The patient is now post-ictal, and the collateral history from the sister is that the patient recently had a URTI, but no fever and no headache. She has a history of schizophrenia and asthma and takes trifluperazine and no allergies. On exam, her vitals are as follows, and her exam is unremarkable. So she's a G2 T1 who's postpartum day number 4. She had 2 years ago, she had a spontaneous abortion, and she's just recently delivered a term female.
How about you, Burke? What would you do now? Knowing she's postpartum, she just had a seizure.
So it sounds like preeclampsia or eclampsia can help. Baby's been delivered, so that sort of is the major treatment there. I would consider starting some magnesium at this point in time. I would love to look at her liver proteins profile again. I know we had it up and it looked pretty normal to me. I just double checked that. Yeah, it looks pretty darn normal. I'd want to look at a baseline blood pressure when she was in hospital recently, and may consider some treatment, but I wouldn't start that right now. Start magnesium.
Okay, thank you. So the talk, as you well know, is on postpartum emergencies. So our objectives today are to review several of the postpartum emergencies, certainly not all of them, as well as the literature around that topic, and introduce a new clinic available to us as well. Which brings me to welcoming our guest speaker, Dr. Sun, who's over here. She's an internist that you may know from doing her training here, and she's done advanced clinical training in obstetrical medicine. So she'll talk about her clinic at the end of our rounds today. And thank you very much for coming. So eclampsia is our first emergency that we'll talk about. Preeclampsia is defined a multisystem disorder with hypertension and proteinuria greater than 20 weeks of the pregnancy in a previously normotensive woman. And it needs to have a systolic of greater than 140 or diastolic greater than 90 as one of those two, as well as proteinuria greater than 0.3 grams in 24 hours, which is equivalent to about a 1+ protein on our dipstick. Severe preeclampsia is an even higher blood pressure. It just needs to have one of these following criteria to be considered severe. Eclampsia then would be preeclampsia plus a seizure. And I just wanted to mention HELP syndrome because some people consider it a different entity, and many people consider that it's likely a form of severe preeclampsia, and it won't be the focus of our talk today, but just to define it. There are two theories about why it happens. One is a theory of brain underperfusion, and one is a theory of brain hyperperfusion. I don't think they know exactly why it happens, but these women get cerebral artery vasospasm from the hypertension, which causes underperfusion, leading to ischemia and cytotoxic edema, which then leads to seizure. Or it could be a loss of autoregulation of cerebral blood flow from the hypertension, leading to brain hyperperfusion, causing endothelial damage, and again, edema leading to seizure. Eclampsia happens in 0 to 0.6 cases of mild preeclampsia, and in 2 to 3% of severe preeclampsia when it's not treated. More than a third of the cases develop intrapartum or within the 48 hours after delivery. And 13 to 16% develop between 48 hours and 4 weeks postpartum, so making it likely that we will see a case of it in our careers. In a retrospective cohort study of 152 delayed preeclampsia patients presenting after 2 days, 22 of them, or 14.5%, developed eclampsia. Most of them presented within 7 days, and the most common chief complaint was actually headache. There are many risk factors for eclampsia. I haven't listed them all, but some of the common ones that we'll probably remember include null parity, a history or family history of it, being at the extremes of age of childbearing, high BMI, and the list is quite long actually. So patients need to present in the context of preeclampsia, so they need to have hypertension and proteinuria. And then the seizure is a generalized seizure or a coma, and there would be absence of other neurologic symptoms. The seizure is tonic-clonic. It's almost always self-limiting, and it usually lasts about a minute, and it would be rare for the seizure to last beyond 4 minutes. Symptoms that women complain about before the seizure include the headache, which we saw was the most common complaint, as well as visual disturbances, the right upper quadrant pain, and altered mental status. The differential is long, and I think there were some good differentials generated already, but things to think about in women of this age include the following list, as well as any of the regular causes for seizure. So the management of eclampsia is based around 4 general principles. The first is preventing maternal hypoxia and trauma. The second is preventing recurrent seizures, because the seizure will probably have stopped by the time you see them, so you're not going to have to necessarily treat a seizure right in front of you, but you'd want to prevent further seizures from happening. You'd want to manage their hypertension, and then evaluation for delivery if they were still pregnant. So the first point, obviously ABCs, you'd want to give them oxygen, especially if they were still pregnant, to prevent fetal hypoxia. Make sure that they're not going to incur any trauma during the seizure, and position them in the left lateral decubitus like we do with pregnant women in other conditions. The second management principle is to prevent further seizures. So this is done with, as Burke was mentioning, magnesium sulfate. There's a lot of literature around why we use magnesium. How to dose it, the major trial that looked at magnesium in eclampsia dosed it the following way. This is really the only good evidence that had a standard dosing regime. So if you wanted to fall back on an evidence-based dosing regime, this is what you could use. So 4 grams IV is a loading dose, and then 1 gram an hour for 24 hours. Some people say up to as many as 6 grams IV, but this is what was used in this trial. And the alternate dosing would be to give, again, 4 grams IV, and then 5 grams IM into each buttock, and then 5 grams IM every 4 hours. And I don't know if I think this would be maybe more in developing countries that they would use this regime. And then a further 2 to 4 grams IV if they had a recurrent seizure. Some people ask, is magnesium safe in renal failure? Well, the loading dose is, and then if you had to give them the maintenance dose and you were following them long, you may adjust it in renal failure. And to mention that it is contraindicated in myasthenia gravis. If you're maxed out on magnesium, like you've given them a lot of magnesium, or they're showing signs of magnesium toxicity, and you need to use something else, UpToDate recommends going to a benzodiazepine. The one most commonly being studied is diazepam. So why do we use magnesium sulfate instead of traditional anticonvulsants? Well, it has to do with the mechanism of action of magnesium. So it's an NMDA antagonist, which prevents the major excitatory neurotransmitter from stimulating the NMDA receptors. So in terms of the cerebral vasodilatation, it decreases ischemia, and it's also a calcium antagonist. And the adverse effects of magnesium are related to the smooth muscle relaxation. So if your patient's getting magnesium toxic, you may see respiratory depression and cardiac arrest. A way to follow along the toxicity is to follow their deep tendon reflexes. So you'll lose those reflexes before you'll have a lowered rest rate or cardiac arrest. So as long as they still have their reflexes, they say that's sort of a rough guideline to say your patient's not magnesium toxic and you don't need to be doing like serum magnesium levels. And if they did become toxic, the antidote is calcium gluconate. So there have been a number of studies that look at magnesium versus some of the other anticonvulsants. This Cochrane review compared magnesium to diazepam. And it found that using magnesium over diazepam reduces the risk ratio of maternal death by 41% and the recurrence of seizure by 57%. And babies also had better outcomes with magnesium compared to diazepam. So it's a long paper, but they conclude that it's superior to diazepam in eclampsia. Similarly, there's a Cochrane review looking at magnesium versus phenytoin. And again, using magnesium over phenytoin reduces the risk ratio of seizure by 66%, but didn't have a statistically significant difference in maternal death. And again, babies had better outcomes, spend fewer days in NICU. So they really think phenytoin should be abandoned. And I suppose if you had to pick a second line, you would go to diazepam, but it's really not recommended. The first line is magnesium. And there's a Cochrane review that looks at how to dose magnesium, like which route and how to give it. Different administration routes for magnesium in both preeclampsia and eclampsia. They were able to include 6 trials of 866 women. 2 of those trials were on eclampsia. Unfortunately, they weren't happy enough with the evidence to draw any conclusions, so they really couldn't tell you if using the loading dose has good evidence for it, if it matters if you use a low or high dose, if what route is superior, or even the duration of the maintenance therapy. So the best results that we have, or the best evidence we have, is back to that collaborative eclampsia trial, which used, and that's what a lot of these Cochrane reviews are based on. So they conclude that clinicians are likely to use a regimen that they are familiar with or follow the local guidelines. And I said you might want to fall back on that collaborative eclampsia trial, because that's really the best evidence that we have on how to dose magnesium. So then the next point, as somebody also mentioned, you want to manage the severe hypertension after you've given them magnesium. So they say that the treatment is indicated if the systolic is greater than 160 or diastolic is greater than 110. And your goal isn't to get their blood pressure to perfect, it's just to lower it to these targets, so below 155 and below 105. So they want you to achieve the diastolic blood pressure target in 2 to 6 hours, but do not lower the blood pressure by more than 25% in the first 20 minutes. And they recommend the following 2 medications in pregnant or postpartum women, which of these are both we know are safe in pregnancy: hydralazine or labetalol, and you could pick either of the 2. And finally, the last management principle is to evaluate for prompt delivery, again, if they're still pregnant. I know this is a talk on postpartum complications, but call obstetrics. And the definitive management for eclampsia is delivery of the fetus regardless of gestational age. And I just wanted to mention the SOGC guidelines on magnesium in preeclampsia and in eclampsia. SOGC says magnesium sulfate, based on the evidence we saw, is recommended first-line treatment of eclampsia. That's well established. They recommend it as prophylaxis against eclampsia in women with severe preeclampsia. So if they had any of those 1 factors that made them severe, they recommend giving it, and that has good evidence. And they said it can be considered for women with just not severe eclampsia, but preeclampsia. You can see the evidence maybe wasn't as strong there. And in their guidelines, they say phenytoin and benzodiazepine should not be used for eclampsia prophylaxis or treatment unless there was a contraindication, like say your patient with myasthenia gravis, or if they were ineffective, like the studies also mentioned. So in summary, on eclampsia, think about it in all women of childbearing age with seizure on your differential. Preeclampsia and eclampsia can present as late as 6 weeks postpartum, so think about it. And magnesium is the gold standard anticonvulsant for eclampsia.
That non-severe preeclampsia, is that oral magnesium?
No, I didn't read about oral magnesium as IV or IM.
One question, just for trainees, one thing I think it's important is when you have your patient in front of you, physical exam can help you if they have severe preeclampsia, because they would be very hyperreflexia, which although it's common in young women, but they should never have clonus. So you should, every patient you worry about preeclampsia, you should always check clonus. If they do have clonus, you know it's indicating hyperactivity of CNS, and they're at high risk of developing eclampsia. And I think OB must have protocol, because in Toronto it's this 4 gram and 1 gram every hour. And usually if anybody with preeclampsia, the OB decided they're going to go have delivery, and magnesium protocol will start intrapartum.
Okay, thank you very much. All right, so case number 2, our next condition, postpartum condition. So it's a 34-year-old female. She's a G4, T4, who complains of headache at triage. She's postpartum day number 15, and she again had a term delivery to a live male. Her obstetrical history is significant for a placenta accreta in her first, and her postpartum hemorrhage in her 3rd pregnancy, but the most recent one was uneventful. Her story is that she had a headache beginning postpartum day number 2. It was occipital, radiating to the temples, gradually worsening over the course of the last, 13 days. Worse when sitting and improved with lying. She had some nausea, but no vomiting, no fever, no trauma. On exam, her vital signs were as follows, and her exam is unremarkable. What would be your differential diagnosis in this case?
Tristan, so this case, we talked about a bad cause of a headache. What do you think in this case?
So it could be simple tension type headache. She could have this could be a nuance of migraine, I suppose, if it was unilateral. I'd be worried, again, because if we're using all the information, that this may be related to some ongoing obstetrical thing, maybe a continued bleed that she hasn't told me about yet. Mass in the head, depending on what kind of symptoms or signs that she's having. Electrolyte abnormalities, toxins, depending, could be a post-epidural headache where she's sort of got a CSF type leak. So.
Thank you. So in fact, that is what we're going to talk about next. Although not an emergency, still a common presenting complication. So this is postural puncture headache. So what is postural puncture headache? And I have to admit, this is the reason I did the rounds, is because I saw a patient with this one day and had never heard about it before. So it's a postural self-limiting headache caused by low CSF pressure following a spinal puncture. So when a woman has an epidural for her pregnancy. And it's puncture past the dura and arachnoid layers into the subarachnoid space that causes leakage of CSF into the epidural space. And in this condition, the fluid leaking is greater than the CSF produced, so there's a low volume in the of CSF, and this causes traction on pain-sensitive structures, and that's why they get the headache. So headache, and this is similar to a post-LP headache. The headache occurs in 10 to 30% of cases of dural puncture and happens more often in younger women. The risk factors would be having just any history of headache, even if it's not related to epidural puncture. Bevel orientation of the needle, so longitudinal to or perpendicular to the longitudinal fibers of the dura, having a larger diameter of a needle, and again in younger females who have lower BMI. What's not a risk factor is physician experience in doing the procedure, the volume of CSF removed, or the duration of recumbency post-procedure, which we'll talk about. They present typically with a frontal or occipital headache 6 to 72 hours after the procedure. It's worse upright and better supine. It's associated with with nausea, vomiting, lightheadedness, tinnitus, neck stiffness, visual changes. So some of those things could be very worrisome, and last 2 to 15 days. So in our case, I think our patient had presented like 13 days after a headache, so toward the end of when you might expect to see them. The first line treatment is conservative measures, so it's reasonable in the first 24 hours when you see these to or in a case of a mild headache, to try bed rest or oral analgesics, including opioids. They or recommend to avoid platelet inhibitors in case you get to the second line treatment, which is certain pharmacologic agents that we'll talk about and epidural blood patch. So this Cochrane review looked at posture and fluids in treating postural puncture, for preventing postural puncture headache. And they, again, like all Cochrane reviews, selected randomized trials and included 11 trials with 1,700 patients. And the trials either had to compare bed rest to immediate immobilization or long versus short period of bed rest. And they found a non-significant higher odds of headache among patients with more bed rest. And I just pulled out the graphic here. You can see that on the bar graph, more of the studies favor mobilization, actually. So although it was non-significant in the end, overall they found that there was no difference whether patients had a period of recumbency or if they were mobilized right away. 8 of the 11 trials had data on just severe headaches. So does recumbency matter only if the headache's going to be really severe? Well, no, they didn't find a significant difference. All the trials looked at just any headache, so not just a postural headache, and they didn't find a significant difference there. So really, it doesn't matter what position you put patients in after dural puncture, which is kind of interesting for us when we do an LP in the emergency department. There may be not a lot of good evidence to have a patient be lying after the procedure. And that Cochrane review also looked at fluids, and unfortunately, it could only include one trial with 100 patients, so there's not a lot of, not a high-powered study. And they prospectively found no reduced incidence or length of headache in patients when they either got 1.5 liters or 3 liters of fluid, which is still a lot of fluid, I think, in both arms. But they couldn't find any evidence to support or refute the use of fluids to treat this condition. So if you're giving patients fluids when you see them, it would be more to make yourself maybe feel better than because of any evidence that it helps. There's a Cochrane review on use of epidural blood patch for both preventing and treating a postural puncture headache. Again, randomized trials. They included 9 studies with only 379 participants in total out of all those 9 studies. So they look at therapeutic epidural blood patch, so that's the one that they would have by anesthesia in the emergency department, versus conservative treatment, so trying things like bed rest, which we know doesn't really do much anyways, or analgesics. And they did find a significant difference in using it, as well as epidural blood patch versus sham procedure. They again look at the blood patch, therapeutic epidural blood patch versus a severe headache, and compared to a sham procedure, it is significant. It does make a difference. And for any headache, not just a postural headache, the conservative treatment, the blood patch did significantly better. So therapeutic, there is evidence, so luckily, because we do ask anesthesia from time to time to come down to do these in the emerge, the therapeutic epidural blood patch does have a benefit over conservative treatment. Just you have to take that with a grain of salt, as the studies they based it on were only 379 women in total. And now to talk about pharmacologic agents in postural puncture headache. So RCTs, they included 7 trials with 200 participants, and they looked at the following 7 medications, so both oral and IV caffeine, caffeine probably being the one we're most familiar with, sumatriptan, gabapentin, theophylline, hydrocortisone, and ACTH. In their selection of the studies, they only found 1 trial with their defined like a primary outcome, which was postural puncture headache persistence of any severity at follow-up. And they found that they did find it to be statistically significant, and you can see here's the bar graph that shows that. Their secondary outcomes, there were a lot more studies that looked at their secondary outcome, which was change in like pain severity scale scores. They found that oral caffeine versus placebo was not statistically significant. And you can see the bar graph here. By and large, the treatment favored placebo, and even the one study that had favored caffeine wasn't statistically significant. So they also looked at change in pain severity score, and these are the following studies they included. So you can see an oral caffeine versus placebo, no, it wasn't significant. Sumatriptan, no. Gabapentin, yes. IV hydrocortisone, yes. ACTH, no. And theophylline, yes. So that's change in pain severity score. They also looked at and defined improvement in pain severity score. They found that oral caffeine improved pain severity score, but that's just, it's a bit confusing, but I think essentially they mean and I'll explain this study, this Kamen study in a little bit, but essentially oral caffeine improved the pain severity score transiently, but overall the change in their pain severity score over 24 hours wasn't statistically significant. It was a transient change that got the patients a bit of improvement, and that's why that part was significant, but overall, did it change their score? No. It's a bit of a wording issue in the studies, I think. And then sumatriptan, again, wasn't significant. So is caffeine and all the other medications, are they safe? Well, there were very few adverse events reported in the studies. In caffeine, there were just 2 cases, one of transient flushing, that's fine. Anxiety, okay, I'm not surprised. And theophylline, there was a case of gastric pain associated with the use of that medication. So in the Cochrane review, they found evidence to support the use of caffeine, gabapentin, theophylline, and hydrocortisone, but they did not find evidence for sumatriptan and ACTH. And I would just say, like, that Cochrane review is based on 200 patients over 7 studies. So again, it's not a hugely powered study. So in summary about post-dural puncture headache, positioning post-dural puncture does not matter. Fluid supplementation has not shown to improve outcomes, so you don't need to do that. I didn't talk about it, but prophylactic epidural blood patch was also looked at, and it was not statistically significant. It didn't help patients. The therapeutic blood patch did, so doing it once they developed the headache did show an improvement. Of all the pharmacologic agents, caffeine had the strongest evidence, but there was limited evidence to also support the use of gabapentin, theophylline, and hydrocortisone. And I'm not sure how often that happens, but there's a small amount of evidence to support it. So with the caffeine, should I give it orally or IV? Well, this was the one study that was a bit confusing, and this is the one that the Cochrane reviews are based on, was the effects of oral caffeine on PDPH. So it was a study, a randomized control trial, comparing oral caffeine to placebo of 40 patients, and all of their outcomes were reported using the visual analog scale at 4 and 24 hours. They gave a single intervention, so 1 dose of caffeine orally, Caffeine had better scores, like I said, at 4 hours, but then at 24 hours, the effect was lost, probably because like any medication, caffeine's not going to work forever. So like an ibuprofen or a Tylenol, it's going to help temporarily, but it's not going to fix the problem. So at 24 hours, there's no difference in their pain severity scores. So it provides temporary relief. An interesting point, because this is going to be used in patients who are potentially breastfeeding. Well, is caffeine excreted in breast milk? Well, yes, it is. It's excreted in the amount of 1% of the maternal dose per liter of breast milk. And if you think a 300 milligram caffeine tablet is going to excrete 3 milligrams of caffeine per liter of breast milk that the baby takes. So I wanted to compare that to a cup of coffee, because maybe there's a lot of caffeine in coffee, and women are breastfeeding and drinking coffee. So I went to the gold standard for how much caffeine is in a cup of coffee, which is Tim Hortons coffee. And you can see that extra large coffee has 240 milligrams of caffeine. So it seems to me that you could discuss giving them caffeine. And if they're a patient who's like, well, I already drink a coffee a day, I'm fine. If my baby has a bit of caffeine, then they're probably going to be okay with the caffeine treatment option. But if they are abstaining from caffeinated beverages, they might not want this treatment. And I just want to mention caffeine as well as on the FDA's drug risk scale. Caffeine's a pregnancy risk factor C. So, and we know it's a little bit of it's transmitted to breast milk. So, okay, and now what about IV caffeine? Well, it's administered as caffeine sodium benzoate. And if you were going to administer it, you'd put 500 milligrams in a liter of normal saline over an hour, and you have the option of repeating if you want to. Unfortunately, there's no trials comparing whether oral or IV caffeine is better. And there's not a lot of evidence on it to be in general. So I think if you're going to administer it to a patient in this scenario, it's kind of a matter of convenience, cost, patient preference, what the emergency department is looking like that day. So I can see there's definitely evidence for both oral and IV caffeine. I think it's going to be up to you having a discussion with the patient to see which one is more amenable to them. And the only other thing I wanted to say about postural puncture headache is it's not an emergency, but beware of things that could potentially be an emergency, masking as this condition, and some of the things that we've already talked about. I found an interesting case report about a postural puncture headache that was actually not that. So it's about a 30-year-old female who at 42 weeks had 2 unsuccessful attempts at an epidural, and the procedure was aborted. She went on to deliver a healthy baby by C-section after she failed to progress. On the first day postpartum, she developed a severe throbbing headache, which was relieved by lying down. She was treated with caffeine, and she refused to have an epidural blood patch. On the 3rd day postpartum, the epidural blood patch was performed. She asked for it. It wasn't forced on her, and it did give her some relief. And 1.5 hours after the procedure, she developed a hemiparesis and decreased level of consciousness. She went on to have a CT scan, which showed both an old and new intracranial hemorrhage. Patient eventually recovered, and her only long-term deficit was having epilepsy. And there were several theories in this article about why she had this intracranial hemorrhage. But all of that to say, not all postpartum headaches are postural puncture headaches. And just have a healthy respect for other things that could be headache. If they had an epidural, that's not the obvious diagnosis necessarily. And I want to mention this too. Does postural puncture headache left untreated lead to subdural hematoma? Well, these authors published this case report in 2006 of 46 cases in the literature where postural puncture headache led to subdural hematoma. And they theorized that it was from the decreased CSF leading to decreased intracranial pressure. So you had caudally directed movement of the brain and spinal cord, which tears the bridging veins, which are thinnest in the subdural space. So that resulted in bleeding into the subdural space. So have a healthy differential for PDPH, and it should also always have a normal neurologic exam. So if you have a neurologic finding, you should expand your differential. Case number 3 is a 30-year-old female who's a G1T1 complaining of shortness of breath. She's postpartum day number 10, and she again had a term delivery to a live female. and was home in 24 hours. So her story begins with shortness of breath on postpartum day number 3, so it's been going on for a week. She first noticed it on exertion, but now it's at rest for the last 3 days. She came to the emerge because I just felt like I just couldn't get any more air in. Her shortness of breath was associated with heavy retrosternal chest pain for 24 hours. And of note, she had no cough, hemoptysis, fever, vomiting, or trauma. On exam, her vital signs were as follows. And her physical exam revealed 3+ pitting edema, as well as bilateral coarse crackles. So what would be your differential in this case?
Natalie, what are you thinking to start for this postpartum shortness of breath?
So I guess the first big concern that kind of pops into my head is, could it be a PE? Just because we know pregnancies is hypercoagulable. I think that's on the list of things, I think, pneumonia or some more common things are probably more likely. I don't recall if she had any sort of asthma or anything like that.
She was totally healthy otherwise.
So a URTI, those are probably more likely. But thinking about PE, and then I'm trying to remember if there's any risk after. I think there's something vascular. I don't remember if they're at risk for dissection or something. I'm trying to remember what my brain's trying to trigger me there. But
Anything else that you're so like a postpartum myocarditis or pericarditis, like a pericardial effusion, or a postpartum cardiomyopathy, and then amniotic fluid embolism, I think would be on the list.
This is her ECG. I don't know if anybody had any thoughts about the ECG.
So it's sinus rhythm, regular rates approximately 100, narrow complex. Looking at intervals, PR interval looks like it's about normal. It doesn't look like QT is prolonged. I don't see any regions of skin. It looks pretty normal to me.
I'm going to talk about peripartum cardiomyopathy, as a couple of you mentioned. So it's a rare disorder of unknown etiology that causes heart failure in women late in their pregnancy or early postpartum. And it's a diagnosis of exclusion amongst the cardiomyopathies. There are 4 diagnostic criteria. So you have to develop heart failure in the last month of pregnancy or within the first 5 months of delivery. You can't have another cause for heart failure. You have to have absence of recognizable heart disease prior to the last month of pregnancy. And you have to have LV systolic dysfunction. And just to mention, there's pregnancy-associated cardiomyopathy, and that would be a cardiomyopathy developing before the last month of pregnancy. So it's on the spectrum of peripartum cardiomyopathy. Why does it happen? Well, it's unknown. There are a number of theories that I've listed here about why. We'll talk about a couple of them. It could also be multifactorial, but really we don't know why. There are risk factors for it, including being age over 30, multiparity, multiple gestations, a history of eclampsia, cocaine abuse, and more than 4 weeks of oral tocolytics are also a risk factor. The most common complaint is dyspnea, not chest pain, but it can present with chest pain and other symptoms, including cough, orthopnea, PND, hemoptysis, and fatigue. And it further, as somebody pointed out about PE, it further increases the risk of systemic and pulmonary emboli beyond that of just pregnancy. So you kind of have like 2 major risk factors now for developing a clot. The ECG findings are pretty non-specific, so there's nothing pathognomonic that you'll see on the ECG that'll tell you this is postpartum cardiomyopathy. Sinus tachya is the most common, but there could be other non-specific findings. On echocardiography, you'll see a global reduction in contractility and LV enlargement without the hypertrophy. You may see left atrial enlargement, mitral or tricuspid regurg, and a small pericardial effusion. The differential diagnosis includes a lot of underlying heart problems that have just now come to light because the patient's pregnant and they have increased physiologic demands, as well as a few other kind of rare things. Pulmonary embolus is definitely on the list, as well as a pregnancy-associated MI, which would be very unfortunate. The treatment is similar to the approach of other dilated cardiomyopathies. You and it's things that emerge docs do well already. They optimize hemodynamics and provide symptom relief. So I want to talk about some of the medications we could use to treat like heart failure or peripartum cardiomyopathy. These are a lot of the drugs that are selected, and I just wanted to put the FDA, again, the pregnancy risk factor up here. You can see that anything that works on the renin, angiotensin, aldosterone system, like ACEs and ARBs, are a bad idea in pregnancy, so avoid those. And everything else is sort of class C, including things that we use commonly like beta blockers, like labetalol, as we talked about, and hydralazine. So it's just to say that risk cannot be excluded in using these drugs, but they're things that are used in pregnancy already, so you'd feel comfortable using some of these medications that are listed as class C. Oh yeah.
Meghan, I just want to mention something about FDA, this classification. As a clinician, we're really moving away from using that because it's very out of date, and really we have a lot of new data. So now it's more popular. We use mother risk. That's actually better, more up to date, and also referral. That's another database. You do need a subscription for that. So that's why these are not very useful clinically. That's how we find. Yeah.
Okay, thank you.
And for ACE in breastfeeding, it's not all the ACE we use. We use the one with most data is enalapril. And we don't use other type of ACE during breastfeeding either. We don't use ramipril in breastfeeding, and we don't have a lot of data. Yeah.
Okay, thank you. And then I could have updated the slide, perhaps the mother risk. That's a good suggestion, but these would be a couple inotropes that you might consider using if the patient was really sick. Talking about anticoagulation, as we talked about, pregnancy is a hypercoagulable state, and then the stasis due to the LV dysfunction further increases the risk of clot formation, so they're at high risk for thromboembolism. And if you had to choose an anticoagulant in the eMERGE, the literature would recommend low molecular weight over unfractionated heparin, and certainly not warfarin in pregnancy. Bromocriptine is currently being prospectively evaluated as a future treatment, and it's thought to, we know that it blocks prolactin, and prolactin is thought to be implicated in the development of peripartum cardiomyopathy. So it's something that we may see, but isn't, there's not a lot of good evidence right now to use it. And then heart transplantation would be a last resort. It used to be that I think almost a third of these cases got heart transplant, but currently it's only required in like the very severe cases, of around 5%. Implications of having this condition: peripartum cardiomyopathy occurs in the last month of pregnancy to 5 months postpartum. So, I mean, if you had to deliver the fetus, you'd be at 36 weeks to 40 weeks. So that wouldn't be, certainly the baby would be almost near term. And generally, breastfeeding is not advisable just due to the medications that they might be taking, although maybe there are certain medications that would be safe, and the woman could certainly be encouraged to breastfeed. But generally, due to some of the medications they have to take, breastfeeding is less desirable. There is a wide range of like how sick they can be and also how well they recover, and it's related to how bad their LV function is at the time of presentation. So generally, people who present sicker have poor recovery, and people who present with mild LV dysfunction generally do better. But any woman that doesn't completely recover should be advised to avoid pregnancy in the future. And women who totally recover, they may try again, but they should be educated beforehand that they carry a high risk of this recurring, and the next time they might get really sick when this happens. So it's really going to be, that would be a discussion they would have with several specialists, like outside of the eMERGE, for sure. So there's one Cochrane review on treating peripartum cardiomyopathy. This is actually the only Cochrane review on this topic. Again, randomized controlled trials. And they search for studies on basically anything related to the topic, like treatment, how to monitor them, supportive therapies, heart transplant. And they found one study that met their approval. It was of 20 women treated with bromocriptine in South Africa, and they just couldn't really say much about it. So it's just to say there's not a lot of evidence for some of the things that we might do in this rare presentation. I found this review article about evaluating and managing peripartum cardiomyopathy. It was published in an Emerge journal. So some considerations, things to think about, ABCs, yeah. They mentioned in this article, there are no contraindications. If you have to RSI the patient, you would do it as you normally would. Like, obviously, airway takes precedence over, like, some teratogenic effect of a medication. And things to think about ordering, ECG, I guess don't forget the liver enzymes in there. Definitely a urine on any pregnant lady, chest x-ray, all the things that were presented in the case earlier. And they talk about sort of the 3 management principles of the hemodynamics. So you want to reduce the preload and medications that you could use, nitrites, morphine, furosemide. This isn't rocket science to the people here who've treated heart failure many times. You want to reduce afterload, and they suggest in pregnant people anyways, hydralazine is a way to do that. And inotropy, dobutamine or dopamine if they're sick. So, yeah.
The last case, what was EF in that patient? Because if her EF is normal, the most common diagnosis in that case, it's a very interesting case. We see that a lot. And I don't know about Emerge here, but it's very common preeclampsia present like postpartum or postpartum congestive heart failure. It's very common because they have very leaky vessel. And also after delivery, during delivery, you have 20% auto transfusion back from the mother. And also we know preeclampsia, the flare, gets worse in the first 48 hours. And these women get discharged home very early, and frequently we see them coming back to Emerge like that. And also one important thing for us to know is when you talk to the woman and say, oh, did you have preeclampsia, toxemia? They say, no, I didn't, my pregnancy was fine. But a lot of time their mild preeclampsia get missed from an OB side. So when they come through to you guys, then you can talk to them a little bit more, and also ask how big was your baby, because baby was a one target organ for preeclampsia. So a lot of the baby size would be small. That can give you some evidence that maybe they've already had preeclampsia. So if that woman echoes normal, may not be peripartum cardiomyopathy. So you didn't know the.
I think in the end, I think she fully recovered, so I think it must have been mild. I just can't remember because she did have an echo very shortly. I think it was like 40%. It was mild. I'm pretty sure.
So that sounds like a peripartum cardiomyopathy. And one important thing I learned actually in the last year is in pregnant women, if you have S1Q3T3, the classic ECG, does not tell you it's a PE because it's very common in pregnancy because anatomy change. So when you see the ECG, we don't get as excited compared to non-pregnant people. Yeah, that's something I learned recently last year.
Thank you. All right, so to summarize, I talked about 3 postpartum conditions, but the list of things that can happen postpartum is vast, and this isn't an inclusive list. Just one of the things I had wanted to work on was my postpartum differential, because I didn't have good ones. I'm still working on them after making this presentation. But think of some of these things in women of childbearing age that come in. We've met Dr. Sun, and I just wanted to give you a chance to talk about your practice and how we could refer patients to you if we saw somebody in the Emerge.
I just came back around Christmas time, so we're working with OB to start OB medicine clinic because things have changed. We're dealing with older women pregnant and with more medical problems. So that's still being discussed. But now most easiest thing is to just refer to urgent medical clinic with my name, and I'll see them. And postpartum, definitely, a lot of these patients get lost follow-up because family doctors don't know what to do with them. But make sure the proteinuria gets resolved. There's no underlying renal disease, no secondary hypertension. So these things are, I think I can help. So if anyone needs any help, I'm there to help. And I also have my own general medicine clinic Thursday morning with no RN and just by myself. So I pick some patients go there if they're wheelchair bound or pregnant, maybe they have to go to urgent medical. So at least I have nurses. So I'm there to help if you see anyone that I can follow, I can offer follow-up. It's not a problem.
Thank you very much. So these were the references I used, and if there are any questions, Mansa.
Might be a good time to talk about referral guidelines. I know this is an outpatient clinic, but I've had a few of these cases with quite a bit of kickback from OB.
They should be all admitted, like if within the first week or two,
Yeah.
I think they should be all admitted.
The question is to who, because with preeclampsia, they'll say if it's postpartum, call ICU, call neurology.
Yeah, because
No
I think
neurology.
medicine should not refuse them. Definitely, in Mount Sinai, we have these people bounce back very frequently. They come back postpartum day 4, hypertensive, and you can't send them people.
Do they get admitted to OB or?
Most of the time, within 1 week or 2, they go to OB. But if they're a little out or not too sure, they come to medicine. Because we have also we have an OB interns like me in Mount Sinai too. But these people, it's high risk for you to send home, especially within the first week, because they can seize, they can have intracranial hemorrhage. I saw press, and I saw someone went to walking clinic with blood pressure high, postpartum emerged. The walking doctor gave antihypertensive, sent him home. A week later, already stroked out, like hemicresis. So they should be all admitted.
I think the local OB guidelines are that they'll only follow postpartum hemorrhage and infections. Anything else should go to neurology or medicine or ICU. But then those guys will not take a post-OB patient. So I've been in situations where it's caused a lot of grief and several telephone calls. So I don't know if Gary wants to address that and see if there's any guidelines in the process or.
Oh, guidelines, that's a whole other issue. We've had, and just for clarity, this was brought to MAC 2 years ago. We asked all departments to provide guidelines for referral to clinics, referral to services, and there were some that were very compliant. The vast majority were not compliant.
I think they could be a short admission. After 48 hours or 24 hours, their blood pressure come down, they feel good, and they can go home. But they should be monitored.
So my current practice is still to call OB first and get the kickback and then.
Yeah, because I can talk to my division. I think medicine, these patients come in, definitely we should provide support. If they're good, the next day they can go home, or 2 days they go home, and we can follow them too. Okay.
Were there any other questions? Yeah, Dr. Theakston.
Megan, your readings about the postural headache, did you come across any estimate about the incidence of infection post-epidural?
Oh no, I didn't. I didn't look for.
Is that something we should worry about? Because as you pointed out in your presentation, some of the symptoms, neck stiffness, headache, could be, early marker of CNS infection.
Yeah, I think that's a really good point, and I didn't specifically search for that. Although any article that I read about it didn't even mention it as a complication of it. But then again, I didn't specifically search for like meningitis, encephalitis, like as a complication of that. So I should probably do that. But no, I didn't come across it in any of the other articles about the complications of postural.
Must be pretty rare.
Must be, yeah. I'll look it up. Well, thank you very much, Dr. Sun, for coming to our rounds and providing that extra information. And I think that wraps it up for this morning then. Thank you.